Good morning, everyone, and welcome. We are so glad that you are here today. As Nick mentioned, I'm Karen Forston, the Chief Executive Officer at the Prevention of Blindness Society of Metropolitan Washington, a charitable nonprofit which serves our local DMV area and focuses on eye health at every stage of life. We have operated in this area for over 85 years, and while we do a variety of programs, serving children has been at our DNA from the start. We recognize that it takes a lot of people working together to ensure that all children can take advantage of every opportunity and thrive, including supporting their vision. A quick stat for you, and you'll probably hear it a few times today, is that 80% of what a child learns is through their eyes. So it's vitally important. Today, we have a program to review essential vision milestones, review local resources that are available to help children, and then a Q&A. Moderating today's program is POB's Senior Director of Children's Programs, Nikki Sanders, and I will turn this over to her.
Thank you, Karen. Good morning, everyone. I am honored to be your host and MC for today, and I have the pleasure of introducing our keynote speaker. So Mohammed S. Jafar, MD, is presently the Dorothy J. Kara and Mark Weinstein Professor and Chair Emeritus of the Children's National Department of Ophthalmology and Professor of Ophthalmology and Pediatrics at the George Washington University. He is the past director of the Pediatric Ophthalmology Fellowship Program, the oldest, largest, and most prestigious such fellowship in the world. Dr. Jafar is a sought-after clinician, teacher, and speaker who is internationally recognized as an authority in pediatric ophthalmology and strabismus. His opinion is especially sought for his expertise in the diagnosis and management of infantile glaucoma and complicated strabismus in adults and children. Dr. Jafar is the author of a number of original scientific papers, abstracts, editorials, and book chapters. He also serves on the editorial board of a number of ophthalmology peer-reviewed journals. He is a member of many prestigious organizations and notably chairs the advisory board of the International Pediatric Ophthalmology and Strabismus Council. Dr. Jafar is a member of the Alpha Omega Alpha Honor Medical Society and has received the Lifetime Achievement Award of the American Association for Pediatric Ophthalmology and Strabismus, the Senior Achievement Award of the American Academy of Ophthalmology, the Professional Achievement Award of the Prevention of Blindness Society, the Children's National Hospital's Sauber Award for Medical Excellence, 3 Golden Apple Awards for Teacher of the Year, and many more commendations, medals, and recognition awards. Dr. Jafar has been consistently listed as Best Pediatric Ophthalmologist in America's Top Doctors, Washingtonian, and many others. And we here at POB, the Prevention of Blindness Society, are fortunate that he chairs our Medical Advisory Committee and is with us today to share an overview of important considerations for children's eye health. Thank you and welcome, Dr. Jafar.
Thank you very, very much, Nikki, for this beautiful introduction. And thank you, Karen and Nick and Sean and everybody for the invitation. I greatly appreciate that. I hope you can hear me and that you can also see my slides. Would you signal that you do? You do? Okay, thank you so much. Again, thank you all for joining us this morning. I'm going to talk about children's eyes, cover some facts, some very well proven facts, and also some myths. I have no conflict of interest disclosures to make. Let's start by covering screening for eye diseases, why and how. And this is really important. But before that, I would like to compare ourselves, pediatric ophthalmologists, to our colleagues in adult ophthalmology. Yes, in pediatrics, we do deal with small people. We have to gain their trust, be able to get information from them and make them cooperate in the exam. But also we deal with small eyes, which is a challenge by itself, especially when it gets to surgery. However, it does not end there. The real reason why there is a pediatric ophthalmologist as a subspecialty is that we deal with amblyopia, lazy eye, binocularity, the ability of the two eyes to work together, and depth perception. And these three phenomena, amblyopia, binocularity, and depth perception, develop in childhood, need to be detected in childhood and treated in childhood. Otherwise, we would have missed the boat. And this is really the huge difference between pediatric and adult ophthalmology. So to go to the definition of amblyopia or lazy eye, it is a decrease in vision development that happens when the brain does not receive normal stimulation from one or both eyes in childhood. It is an abnormal development of vision that leads to permanent loss of vision if not detected and corrected early. So we have two words on this slide that are in capital letters, childhood and early. We have to detect these early and treat them early, otherwise we can't be successful. Again, amblyopia is a reduced central vision. You cannot see 20/20, you see 20/40, 20/50, 2100. In the absence of any organic cause. So the child may or may not need glasses, you give them glasses and the vision still does not improve. The patient might have cataract, you take the cataract out, but the vision does not improve because of amblyopia. There are many reasons why amblyopia can occur. We are all familiar with strabismus, a crossed eye that in lay people's terms, we call it many a time a lazy eye. We can see here and to the right that the child has a normal fixing left eye with a vision of 20/20. However, the right eye that is crossing does not get better than 20/80 vision. But any other reason that does not allow the child to see well, like a corneal opacity, a cataract, a vitreous hemorrhage, a lid hemangioma, drooping of the lid, nystagmus, and so on, all these things can cause amblyopia. Anisometropia, having one eye that is farsighted, the other normal, will make the child see one with one eye, neglect the hyperopic eye. We call this anisometropia, and secondarily a lazy eye, or severe emetropia, a very high refractive error. These are some examples. We covered already the patient with strabismus, a crossed eye causes amblyopia. Here, up and to the right, the child cannot really see because the left upper lid is covering the eye completely. Down and to the left, the patient has a cataract. In childhood, the vision doesn't develop well, or a corneal opacity in this specific case due to glaucoma that again obscures the vision. So these are just examples of why vision is decreased in children, and because of that, the brain does not develop a good vision, and this is why we have lazy eye. Something that is not apparent to the examiner, casual examiner, to the pediatrician, to the parents, to the teachers, is when the eyes are straight, there is no opacity, there is no drooping of the lid or anything like this, but there is a difference between one eye and the other. Please concentrate on number 3, up and to your right, where we can see that the patient's left eye is normal. The image is well focused on the retina and sending a clear focused image to the brain. However, on the right, the image is focused behind the retina because the child is farsighted. On the retina, we have a blurred image. The right eye sends a blurred image to the brain doesn't like it. The brain shuts off that eye, develops a lazy eye. And down and to the left, we have a cataract that can cause the same thing and so on. So again, these drawings show that you can have straight eyes, no corneal opacities, nothing apparent to the outside like a cataract, a white pupil, but still we need to detect these conditions to make sure that the child does or does not have amblyopia. Why is amblyopia screening important? Well, it is quite common. Around 2 to 3% of the population has amblyopia. It's usually preventable. It's usually unilateral, but can be bilateral. Early detection is key to effective treatment. I've already overemphasized that several times. The treatment depends on the plasticity of the visual system, meaning that we have to intervene when the child is still developing in the first few years of life, usually up to 6 or 7, but the younger, the easier the intervention and the better the response. And sometimes life-threatening conditions like tumor, a retinoblastoma, or optic nerve hypoplasia can be detected because we have now a child who has poor vision. So by examination, we could detect the other more morbid conditions causing that poor vision. And last but not seen, vision screening for amblyopia is now recommended as part of the American Academy of Pediatrics Bright Futures periodicity schedule. So the pediatricians, by training and by recommendation of their own society, have to have the child do vision screening as part of the well baby exam. Again, it is 2 to 3% incidence, meaning 100,000 new cases add every year. And it's quite prevalent. Around 12 million Americans have amblyopia, with half of them with a vision less than 20/80, which is way down from being able to pursue a lot of professional careers or driving or the like. And it is important because study after study has shown that people with amblyopia or any decrease of vision in one eye have almost 3 times the risk of visual impairment in their better seeing eye to less than 6/12 or 20/40 compared to people without amblyopia. And this is significant. So you have one good eye that suddenly lose the vision and you are now left with a vision less than 20/40, which means that that person cannot have an unrestricted driver's license. That person cannot have a normal professional career. Of course, with some accommodation you can, but not an unrestricted career. Are there barriers to screening? Yes, unfortunately there are. Poor cooperation of a young child. It takes time to perform. Many staff members in pediatricians' offices are not adequately trained. And there is a poor reimbursement for physicians. So because of the squeeze and the limited time and effort, a lot of people just don't do it, but we should and we will. All these screening guidelines that I'm going to cover are age dependent. The younger the child, the more lenient we are, and the older, the more stringent. For instance, for visual acuity in the first 4 years of life, 36 months, 47 months and below, we would pass anybody who has a 20/50 vision or better. 2 years later, 20/40, above 5 years of age, 20/30. And these exams should be repeated every 1 to 2 years, making sure that, you know, the child is examined. You know, many a time we go to schools and the child is out sick or the child is on vacation with the family or something like that. So we may miss these children. This is why going back to the same schools and so on every year is extremely important to make sure that we are not missing anyone. And when we check the vision, we have to check each eye by itself, up and to the left with this cute smiley face behind the eyeglasses. This is the worst ever way of checking vision because the child is bright and can peek between the frame of the glasses and the smiley face. Excuse me. Best way of doing this, if we can use a patch, this is very efficient. The patch goes directly onto the eye. And if the child wears glasses, the glasses are worn on top, or you just get a 2-inch tape and just stick it on one eye and then take it and stick it on the other eye to measure. And we can see how children can respond. If we're looking at numbers, the child can gesture with the numbers. If the child the child wants to show us how the E is pointing, they can point the fingers up and so on. So a lot of different ways, but again, let's make sure that the child is not peeking when we're checking the vision one eye at a time. There are a lot of visual acuity charts that are on the market. As you can see, these are a little bit different from the old ones where, you know, they will be like rectangles. Here, the letters or the symbols go in a V shape, and we call these Sloan charts, where the separation between one symbol and the other, the separation between one line and the other are all in the same proportion. These are called LEA symbols, HOTV, 4 letters of the alphabet that is easy for the child to see. And we also have a small card where the child can match what they're seeing on the screen. And of course, for the literate patient, they can read a regular chart. Different charts are available, as I said earlier. One way is to do the threshold screening, where the child would read down the eye chart until a threshold line is crossed. This is around 2030, the red line in here. And the child maybe can read the first letter on the left, D, C, V, S, K, until they stumble and they can ask them to read the whole line. And for the other eye, they go on the right side with the O, Z, N, etc. Easy, you can compare one eye to the other, but it's a little bit more cumbersome. It may take a little bit more time than if we do the lines, the critical line screening, where we can have either symbols or letters. The top large letters are for demonstration, and once a child knows this is a square, a heart, a house, a circle, then with one eye we ask them to read this line, and with the other line, the line to the bottom. If they pass, they pass. If they don't, then they are referred for a more comprehensive examination. And again, different types of charts with letters, numbers, symbols, and the like. These symbols that I have here up and to the left are called LEA symbols, after Dr. Lea from Sweden. And they are well tested, where it is very hard for the child to guess, and they really need to have good vision to be able to read them. Different than the old slides where we have a telephone and a house and birthday cake, where a lot of guessing can happen. APOS, the American Association for Pediatric Ophthalmology and Strabismus Society, has vision screening kits where you have an occluder, you have a 10 feet cord to measure where you are from, and different types of charts. They are commercially available. And there are also a lot of electronic apps, be it on computers or cell phones, that can be also used. Again, many ways of checking the visual acuity of a child are available. Let me now move to the instrument-based screening. These are no longer experimental. These are valid methods for screening very young children to detect the most common conditions producing visual impairment in children, like amblyopia, high refractive error, strabismus, media opacity, like a cataract. They are recommended to be used between ages 1 and 3, and they are commercially available, and they have been tested both in the field and in research, and quite reliable, have good sensitivity and specificity. The American Academy of Pediatrics and the other societies recommend using those instrument screeners between age 1 and 3 until the child can read an eye chart. And the eye chart, where with direct measurement of the visual acuity, remains the gold standard for vision screening, and can often begin by age 4 and many a time before that, because children are now so much exposed to reading and so on. So again, if we can, we jump directly to the visual acuity chart, because there we really know if the patient does or does not have amblyopia. Again, with the vision chart, we can tell if the patient sees 20/20 in one eye, 20/60 in the other. Done deal. We don't know why, but the child doesn't see well with one eye, and the child needs a comprehensive examination. The vision screening devices typically do not test visual acuity, but they test to see if the patient has high refractive error, has myopia in one eye but not the other, astigmatism in one eye but not the other, has a corneal opacity, opacity in the lens, or anything like this. So they detect more a disease and not as much what the child can really see. So again, if possible, checking the visual acuity with the chart is the way to go. And this is a very quick example on how photoscreeners or autorefractors work. You get a quick image from each eye. You look at the red reflex, and depending on how symmetric or asymmetric the red reflex is, as you can see here in the gray picture, one reflex is smaller than the other. And the machine can interpret that and say, well, this child has more hyperopia in one eye than the other, or this child has a cataract in one eye, but not the other. So it's a quick way of detecting disease processes. And as with the visual acuity testing, there is also a threshold that goes with age. The younger the child, the more lenient we are for a difference between one eye and the other. And the older the child, the more restrictive we are. All those machines come with different instructions from the manufacturer that are quite easy to understand and to perform. These are examples of some instruments available in the market. The Welsh Allen Spot and the eye screen up to in the middle and to the right are the most commonly used instruments in our area. They're reliable, high sensitivity and specificity. But there are many, many, many others than what I'm showing here in those 5 slides. The examiners stand at around 1 meter distance from the child. This is on the left. This is a child who's sitting there just for demonstration. I'm sure she can do a visual acuity chart and she does not need the vision screener. But this is for demonstration. And in here we have an infant in mom's lab where the examiner can snap a picture in a few seconds and off we go. Very reliable. So instrument screening is useful for children between ages 1 and 3. And between age and 3, sometimes if the child cannot do the acuity chart, so we can start at least with the instrument screening. And in older children who are nonverbal, developmentally challenged, or otherwise unable to perform testing with acuity charts for, poor attention span or whatever it is. So again, do the visual acuity chart if you can, but otherwise the screeners are there to help. So this new technology that is not very new now, in the last 5 years or so, we have adopted them. They make it possible for a future where all children get screened. The result will be the early referral of more children at risk of amblyopia and strabismus. In this way, we can treat them and get a good prognosis out of them. And we will be eliminating the #1 cause of needless and permanent visual loss in children and young adults, amblyopia. So if the child fails a visual acuity chart or fails the instrument screening, they are referred for a comprehensive ophthalmology or optometry examination for the proper treatment. And those who cannot afford the APOS, Pediatric Ophthalmology Society, and the Children's Eye Foundation have created the All Children See program, where families with limited resources or no insurance can be seen by volunteer ophthalmologists in every community all over the United States. Sean, Nikki, and Karen can share with you how to get hold of this program if you all need it. I'm going to move to another subject that is taking a lot of attention these days, the myopic pandemic. We know for sure that there is increased myopia with every generation. The parents are more nearsighted than their parents, than the grandparents, and the children are definitely more myopic than the parents and grandparents. Is there any genetic background? For sure there is. Parents with myopia are going to have children with myopia. Is it because we are more of a literate society? We spend more time reading and doing work on computers and gadgets and so on. Is it because of this exposure to electronics and digital games and gadgets? Is it because we live in a higher electromagnetic field exposure? Or is it just because we are a more urban population than before? We don't know, but I'll get to it later on. what to do to prevent myopia? How can we delay its onset or slow down its progression? A lot of things have been tried and are advocated to different degrees. A lot of physicians right now are offering the parents atropine eye drops to use every day with different concentrations. We started with the 1% that works, but has a lot of side effects. And ultimately, when you stop it, they will have a big rebound. Believe it or not, a very, very diluted concentration of atropine has proven that it does slow down the progression of myopia to a certain degree. In my mind, in my practice, I do not advocate it because unfortunately, atropine has not shown that there is a huge difference at the end. So both eyes become, if you use atropine or not, they are going to become more and more nearsighted. And the difference ultimately is not going to be very big. So instead of ending up with a -5 refraction, you end up with a -4¼ refraction. Clinically, in my mind, it doesn't really make a big difference. Unfortunately, atropine has not shown that it stops from progression into what we call malignant myopia or degenerative myopia, where the child will have more retinal holes and retinal detachment happening. However, a lot of parents like to do it, and they do it. It's a little bit expensive, and they do it for a number of years, and then they stop. There are special contact lenses that can be used. Orthokeratology lenses are hard contact lenses that the child sleeps with. It changes the shape of the cornea while the child is asleep. They wake up in the morning, the cornea is still flatter than it started with. The child can go without strong glasses. Unfortunately, it has a lot of side effects, and the greatest majority of ophthalmologists do not recommend that. There's now a new contact lens that works on defocusing the image in the periphery versus centrally, called MySight or Ability or any other brands that some ophthalmologists and optometrists are using if the parents insist on. Bifocals have not proven to do the trick. Decreasing reading and decreasing near activities has really also not proven to be of any effect. And also, are we going to ask children not to read versus becoming nearsighted? So even if this is the case, I don't think we're going to recommend that. And last but not least is spending more time outdoors, which has now been proven to be the key point in why we have more myopia than before. Children are generation after generation are spending more time outdoors doing whatever they're doing and less time outdoors. So the being away from the outdoors is apparently why we are seeing more myopia in urban societies than in rural societies. This is why we are seeing more myopia in younger generations than the older ones. So the very strong recommendation right now is to spend 30 to 60 minutes a day outdoors, doing whatever you want to do. You can run, you can play basketball, you can just daydream, do whatever you want. You can read, you can use your iPad outdoors, but it is the type of light that is outdoors that is very helpful. And it doesn't matter if it's sunny or cloudy, rainy, snowy, it is the outdoors light that is important. And then there is a lot of talk about straining the eyes and computer vision syndromes and so on. There is a lot of talk and probably benefit from this 20-20-20 rule. So after 20 minutes of spending time on the screen or reading, take 20 seconds break, looking at 20 feet away. Essentially take frequent breaks. That will relax the accommodation of the eye. That will let you blink a little bit more and will make the discomfort go away. So 20-20-20. There is also a lot of talk about using blue light blocking glasses and filters. A lot of studies have been done after the original one that advocated that. And now the American Academy of Ophthalmology has come out with a very strong statement saying that it does not recommend blue light blocking glasses because there is no scientific evidence that this is helpful. So again, if people want to do it, they look cuter in blue glasses, that's fine. But does it help? It does not seem to be the case. And last but not least, I'm going to cover learning disability, because again, in everybody's field, this comes up very frequently, especially in our area where parents and children are very motivated to do better scholastically. Learning disability is a complex and multifactorial issue. There are specific reading disabilities called dyslexia. There are difficulty in memory, difficulty in mathematical calculations, and there are a lot of other hereditary, psychological, psychosocial, IQ reasons why the person is not developing well academically and can't read. Autism, ADHD. So it is a learning disorder characterized by reading difficulty due to problems identifying speech sounds and learning how they relate to letters and words. So it's a communication issue in different parts of the brain. Dyslexia occurs in children with normal vision and intelligence. These are really bright kids, but for some odd reason, their brain is not able to understand what's being asked for. It is a lifelong condition caused by inherited traits that affect how the brain works. And most children with dyslexia can succeed in school with tutoring, remedial education, and emotional support. It works. So again, you go out in society and there are vision interventions for patients with learning difficulty. Ocular, correct a refractive error, look for poor accommodation, poor conversions, heterophores, and so on, which obviously exist and need to be treated. But there is also a lot of push for behavioral vision therapy, eye movements, hand-eye coordination, improving visual skills and eye-hand coordination. It does not work. I should emphasize that eye defects, subtle or severe, do not cause the patient to experience reversals of letters. Why would a child read the D as a D or the P as a Q? Because we were taught how to do that. It has nothing to do with vision. Flip-flopping letters in spelling, again, has nothing to do with vision as such. And there is definitely no scientific evidence that supports claims that the academic abilities of children with learning disability can be improved with treatment that are based on visual training, including muscle exercises, ocular pursuit, tracking exercises, training glasses, having very weak glasses of 1 or 2 diopters of prism, half a diopter or a quarter diopter of hyperopia in them. Absolutely nothing. It's losing money and time on that. There is no evidence that neurologic organizational training will help. No evidence that the Irene glasses help, the colored overlays, lenses, etc. The red, the blue, the yellow, they just don't help. So what are the risks and harms of visual therapy? Well, they give the parents and teachers a false sense of security that a child's reading difficulties are being addressed, whereas we are really losing time and resources during that. It delays the proper instruction or remediation. And some parents, very few, will swear by it because they say, well, I've done it and my child improves. But the child improves because now 3 to 5 times a day, they are sitting with the parents in a car, going to the optometrist's office, sitting in the waiting room for half an hour, spending an hour with the optometrist, coming back, again, spending time with the family, talking about many things, reading and the like. And the child is getting older 6 months later, 2 years later, after this exercise, the child is older, the child is doing better by themselves. So all these are really anecdotal and there is absolutely no scientific basis for that. So again, don't lose time on that and let the child go to educational rehabilitation. This is where they really will do very well. So The APOS, the American Association for Pediatric Ophthalmology and Strabismus, has many booklets and brochures and so on that can be ordered that, of course, you can read, you can share with the parents, and most importantly, direct those parents into the right resources to benefit their children and the family as a whole. Last but not least, there are the Enchroma glasses that have been advertised or talked about heavily on the media that cure color vision defect. Absolutely not. There is no cure in there. It changes the spectrum of wavelength that the patient is looking through. They give them a little bit more differences in the hues. Some people like it, and if so, that's good. But again, there is no magic in them. It's just giving the patient a different way of seeing around. I hope I shared with you what I know, the facts that vision screening is important. It's important to do it early and intervene early. And there are things that we can do, like encouraging children to spend time outdoors and stay away from unnecessary interventions and concentrate on what we can help our children with. I thank you very much, and I'm going to stop here, and I'll leave it up to Nikki to let us know if she would like to entertain questions now or at the end.
Yes.
Thank you.
Thank you so much, Dr. Jafar. Thank you for your overview of children's vision health milestones, screening instruments, eye diseases and treatment, and definitely for your insight on how we can all support children's vision health for a lifetime. We are going to have a Q&A session after this, so I'm going to move to our next piece. You're going to hear from Sean Curry. Sean Curry is the Associate Director of Programs with the Prevention of Blindness Society of Metropolitan Washington. He manages POB's Low Vision Learning Center and Low Vision Resource and Low Vision Support Group Network and works closely with Prevention of Blindness Society's Low Vision Rehabilitation Program. Sean also leads measurement and evaluation efforts and provides guidance for Prevention of Blindness public health information initiatives. Sean's team works directly with individuals with low vision to maintain their independence. Previously, he worked in public health promotion with Penn Medicine Lancaster General Health. He earned his Bachelor of Science in Biology and Health Science from Lebanon Valley College and his Master of Public Health from the George Washington University. Sean is going to join us and talk with us about vision coverage, vision screening, and vision resources for our area. So welcome. Thank you, Sean.
All right. Thank you, Nikki. And while we are transitioning, I recommend everyone take that 20-20-20 break. So I'm going to share my screen, and it really is an honor to be able to speak alongside Dr. Jafar here. Dr. Jafar is a world-renowned pediatric ophthalmologist, and he's helped saved and helped many, many, many children improve their sight for good. All right, so there we go. Today, so Dr. Jafar covered a lot of the more technical side of things that are extremely, extremely important for the children. And I'm going to focus now on the resources that are available in our community to help children be able to get these vision screenings that are so important. So first, little overview of what I'm going to cover. I'm going to start by just giving basics of vision coverage with insurances and whatnot, as well as where offices are located. I'm going to briefly cover the vision screening requirements for schools set by the states. I'm going to talk about some national level programs and then go over the resources by region. All right, so Dr. Jafar really gave a great overview of vision screenings versus an eye exam already. So I'm actually not going to cover that in addition to what was already spoken. I will share those who provide vision screenings. These are the pediatricians at these regular checkups that they have, school nurses during regular intervals, and then other trained professionals such as the Lions Vision to Learn or the Prevention of Blindness Society, who have received training on how to correctly provide these vision screenings can also do it in the community. A little overview of insurance. So there's two main types to talk about. One is the private insurance. The one point I'll give about that is that coverage does vary based on the provider. So what I recommend sharing with parents is that they should look on the back of their member services card. So that could be found potentially in their wallets or their purses, or wherever they hide all of those cards that they get throughout the day. And that will have a phone number on the back that they can call to hear what vision services are covered under my insurance for my child. Then we transition over to Medicaid, which is the public health coverage option that primarily serves low-income children, pregnant women, and then people with disabilities. And this covers a large number of children. 79% of DC children, 48% of Maryland children, and, or excuse me, 49% of Maryland children and 48% of Virginia children are enrolled in either CHIP or Medicaid. What is CHIP? CHIP is it's the Child's Health Insurance Program. This is the low-cost health coverage that's available to children that are in families that make maybe just a little too much to be covered under Medicaid, but they still have a lower income. And I'll give the percentages here once we get into resources by region. And then we have the well child visits, which are the early and periodic screening, diagnosis, and treatment. That is a lot of words, and often it's abbreviated to EPSDT. And these are the preventive health screenings that children receive when they're enrolled in Medicaid. And these are the normal screenings that a pediatrician will provide. This occurs frequently in the first 3 years and then annually until the age of 20. And a part of these screenings include the vision screening. So now I'm just going to briefly show some mapping over 2020 during the summer when COVID was going on and we were all kind of stuck in our office. The Prevention of Blindness Society did a little research project to find all the offices in the area. So a couple caveats to this. It was done during COVID in the summer, so some offices may still have been closed at the time. In addition, some offices may not be included on websites, or there might be satellite offices that are not included underneath of the practitioner's licensing or under their website. So I'm going to start with optometry and then do ophthalmology. And what you're going to really see here is that the numbers start to go down as we get towards children and children with Medicaid, which is going to really show that there is definite need going on and we need help maybe finding these offices. So now we have optometry offices who see children and accept Medicaid. And then finally, they see children of all ages and accept Medicaid. And then we go to ophthalmology. Ophthalmologists are the medical doctors, so they are true experts at these eye conditions, especially the amblyopia and strabismus and all the things that Dr. Jafar covered. So we see the ophthalmology offices here, and then we want to see those that see children accept Medicaid, and then children of all ages. So you see the numbers quite go down. And you also see some areas that you may see pockets. So you're looking at Southeast DC, Prince George's County, parts of Montgomery, and Alexandria. All right, and then these are the vision screening requirements for schools. This information is from a study completed by Prevent Blindness America and the Johns Hopkins Wilmer Eye Institute in 2020. What they did was they looked at the code laws in the state's law code. So in DC, there's a universal health certificate that requires an annual vision screening for students when they enter childcare facilities, Head Start, and all DC schools. State of Maryland, it's upon entering pre-K, kindergarten, first grade, and then either 8th or 9th grade. And then finally in Virginia, it's upon entering kindergarten, 2nd or 3rd grade, and then grades 7 and 10. Moving on now to the resources, and I'm going to do the national level programs and then the ones that are available in specific states. So first, Children's National Hospital, Dr. Jafar works there. And the hospital has a financial assistance program for children in need. Their goal is to be able to provide the eye care that's needed for children, no matter the cost. So they can work with you to help find solutions for that. Dr. Jafar also mentioned the All Children See program, which is a really great program that helps match children who are either uninsured or unable to pay a copay that failed a vision screening or have other concerning eye conditions with a qualified ophthalmologist. And then they provide a free comprehensive eye exam to these kids. So it's a really great program. And then the Infant C program can help those people find a free comprehensive eye assessment for infants. Moving on to each region, I'm going to go to the District of Columbia, then Maryland, then Virginia. You will notice that there are some overlapping. So if it does overlap, I'm not going to repeat myself and say it all over again. So in the District of Columbia, for vision screenings, the Maryland Lions Community Outreach Foundation serves both DC and the state of Maryland. And they have a screening vehicle that provide vision screenings to children, which includes the screenings as well as help obtaining prescription eyeglasses and access to healthcare providers. Next is the Prevention of Blindness Society of Metropolitan Washington. Our organization provides vision screenings to all DC schools. That includes public charter, private, preschools, and daycare centers. And then finally, pediatricians who provide these will provide vision screenings at normal checkups. Next, eye exams. Now, with eye exams, if you're under Medicaid, they will cover an eye exam every year without a copay. Children are covered in households that are up to 319% of the federal poverty level. The 2022 guidelines for the federal poverty level for a family of 4 was a little over $27,000 a year. So again, it's still not a whole lot. Then there's also the private vision insurance, which again, you want to give your member services card a call and ask them about what's covered. The Prevention of Blindness Society has a mobile pop-up clinic that can provide full service eye care. So this includes the screenings, the eye exams, and prescription eyeglasses to children. And this is completed all at the school or wherever the screening took place to help eliminate a lot of the barriers that are often seen with children who need to find eye care. And then finally, Vision to Learn, which is a national level nonprofit, is coming to DC. They will be providing eye care to some select DC public schools. And this is still developing. I believe it's starting in the fall. So if you're not already aware, just keep an eye out about them. Moving on to eyeglasses. Again, the Maryland Lions Community Outreach Foundation, they will provide the screenings and give help obtaining prescription eyewear. Our pop-up clinic, the Prevention of Blindness Society pop-up clinic, and then also the Prevention of Blindness Society has an affordable eyeglasses clinic that can help provide discount eyeglasses for kids that they may have lost or broken their glasses. If you all work with kids, you all know kids are running around, they can easily break or lose them. And it's for if perhaps their insurance won't cover a replacement pair of glasses. And then finally, Vision to Learn, they provide that eye care to these public schools. Finally, with Medicaid, they will provide a pair of prescription glasses annually without a copay. Moving on to the state of Maryland, a lot of similarities here with the vision screenings. You have the Community Outreach Foundation from the Lions, the Prevention of Blindness Society, and pediatricians. For eye exams, Medicaid will cover an eye exam every year with a very low copay. Children are covered up to 317% federal poverty level. Why it's 2% less, I really don't know the answer, but that's their coverage. And then Prince George's County and Montgomery County have a Care for Kids program. Prince George's is through Kaiser. This program will provide free eye exams to children who are uninsured that live in the county. Then we move on to eyeglasses. And again, you have the Community Outreach Foundation and the Prevention of Blindness Society be able to provide glasses through our mobile clinic, as well as our affordable eyeglasses clinic. And then Medicaid will cover a pair of prescription eyewear each year with very low copay. So Maryland and DC do have a lot of similarities. There's a slight difference here when we get to the state of Virginia. So starting with vision screening, the Northern Virginia Lions here in District 24L provide quite a few services and are very helpful. One is their mobile sight and hearing screening unit. This will provide both free sight and hearing screenings. This van regularly travels throughout Northern Virginia, and you can find the upcoming screening events they have on their organization's website, or you can give them a call. The contact information for all of these things that I'm talking about today is in the resource packet that we shared with you all, and we'll share again at the end of today. In addition, the District 24L here with the Lions have helplines that you can call to find services in your area. The Prevention of Blindness Society and pediatricians, again, there to provide screenings. Moving on to eye exams. Medicaid's a little different in Virginia. They will cover an eye exam every 2 years for children. Children are covered in households up to 143% of the federal poverty level. But if you're enrolled in CHIP, the Children's Health Program, children will be covered up to 200%. What that means is some households may be enrolled in Medicaid, but not in CHIP. So that might be something to look into and have the parents look into enrolling to ensure that they're enrolled in both of those programs to make sure they're getting all the coverage they can for their children. Finally, what's unique with eye exams, the Fairfax County Medical Care for Children Partnership will offer low-income families a reduced cost healthcare program for children, which will include eye exams. So let's say maybe you make 205% of CHIP, the federal poverty level. You may not be covered under CHIP. This is where this may come in and be helpful for them. Finally, with eyeglasses, again, Prevention of Blindness Society has services available. And then finally, Medicaid will cover a pair of prescription eyewear every 2 years, and they will help reimburse the cost for eyeglasses of $20 to $100. So it's not quite as comprehensive as DC and Maryland, but there are still services available for children. So I briefly just went over a lot of the resources that are available. Again, I do want to share that the resource guide that we have available for resources for children and vision care in the DC metro region is available, and we will provide it if you have not already received it. And I do want to stop here, pass it back off to Nikki for question and answers.
So thank you, Sean, for raising awareness of the available supports and resources for children's vision health in our area. And as Sean stated, we are excited to provide our attendees the opportunity to ask questions or share comments. Thank you to those who have already shared your questions in the chat. I'm going to actually read those. You can raise your hand or continue to put your question or comment in the chat. So our first question is, I'm a school nurse and wanted to know if students are getting their vision checked at their annual visits, and is it still recommended that we nurses screen in school? I think that one's for Dr. Jafar. You want to take that?
I'll be happy to try and answer this. The key is children need to be checked. Their vision needs to be checked. Sean was saying that in Maryland, the children are tested up to age, before they enter school, pre-kindergarten, kindergarten, first grade, and then they skip all the way to 8th grade. I think this is a huge jump. I really don't think we should go that far. Of course, by that time, between 2nd grade and 8th grade, the children are a little bit more vocal. The teacher can spot on a child who cannot see, the parents can do that. And maybe this is when they will resort to their own examinations. But back to your point, school nurses really will help a lot in making sure that the children in their schools are being screened one way or another. If they are not, please reach out to organizations like the Prevention of Blindness Society, like the Lions Club, to make sure that they are screened. If this is not available in your specific jurisdiction, encourage the parents to have the child vision screened at the pediatrician's well baby clinics. If these are not available, please call on us at the Prevention of Blindness or on me personally, and we will set up a training session for yourselves, the nurses, at the specific schools for you to be able to screen until a more organized program is adopted. So the key, again, let's make sure that nobody falls through the crack.
Okay, thank you. And also I want to say thank you to Kathleen, who shared that the National Association of School Nurses have access to free VSP coupons for visual exam and glasses. It's for members, and there is a limit of coupons per year, so we can add that to our resources. Sean, thank you, Kathleen. Dr. Jafar, our next question is, understanding that atropine will not stop progression of myopia, is there any benefit to using it to increase dependence of the more myopic eye and train the brain, especially in an age where children are using more and more gadgets, including in school?
If I understood the question correctly, atropine has many studies, a lot of them are in Asia, where myopia is much more prevalent, has shown that they slow down the progression. But what do you do? What does the child do during that time doesn't really matter. So I really don't think we have any evidence to be able to answer your question. My big issue with atropine is that almost every family will stop using the atropine at some point. It is relatively expensive. It is $75 out of pocket per month. The child ultimately would say, enough is enough, I'm not going to use the drops anymore. But most importantly, if you compare the children who did versus did not have atropine, there are two curves. You know, those who don't have atropine goes like this, and the other one is almost parallel. So the difference is there, but it's not huge. But if you look at the tip of my fingers, we're talking about a child without atropine that ends up with, let's say, a -5.5 diopter of nearsightedness versus the other one with atropine, an identical twin, who has -5. So is this half a diopter of difference? Is it really worth the trouble and the effort? In my mind, no. I would jump onto atropine if the atropine shows us that it's preventing the eye from going into a -7 versus a -2, with the -7, -10, and so on. This is what we call degenerative myopia with retinal holes and detachment and so on. Unfortunately, we are not there yet. At least the scientific evidence, the numbers are not there yet to show that atropine has affected that yet. I think there are two different pathologies. Those eyes with degenerative myopia are a different type of eye than the bread and butter myopia that we see, that we are mostly treated with atropine. So again, there is no harm from the low doses of atropine. The child doesn't have a dilated pupil to be very light sensitive. They don't have to wear a hat. They don't have to wear bifocals. So they are more easily accessible than when we used to use the 1%, the higher dosage. And again, if the family is interested, I have absolutely no objection to that. But would I recommend it? I will not personally.
Okay. Thank
That's a
you.
long answer.
Our next question is, could you clarify the treatment for dyslexia?
It is mostly an educational approach, because some children can learn by reading and understanding things by reading, but they cannot understand the verbal instructions that are given to them by the teacher. So there is no good connection between hearing and understanding. There is no good connection between hearing and reading. Some children have issues in comprehending. They can read a whole paragraph, but they have absolutely no idea what they have read. So this is where the educational interventions are important. And these interventions have nothing to do with vision training. It is really an educational system. I always tell the parents, why would a child read the B as a B and the D for David as a D? Because somebody told us, that the B where the line is to the left is different than the D for David where the line is to the right. It has nothing to do with vision. It's just accepting that this is a B for Bob and a D for David. So again, they are all educational issues, and this is why remedial teaching is the key to these issues. Going to training where they draw circles on the wall for half an hour has nothing to do with how well they are going to do in reading and comprehension. But there are specific teachers who can do that. And luckily in our area, there are very good schools for dyslexia, dealing with children with dyslexia.
Okay. I have two more questions so far. One is, can you clarify the issue with blurred vision?
I don't understand the question.
If whoever asked that question could give us a little more detail, I'm going to go to the next question while we wait. You mentioned being outdoors is suggested and for good eye health sight. Is it the light or the vitamin D from the sunlight? Is vitamin D beneficial for sight as well?
We don't know. We don't know. No specific studies have been done about that, but the type of light, it's not the intensity. It's not like what grandma used to say, don't read in the dark at night. It has nothing to do. So putting the lights up inside the house has nothing to do with it. It is the quality of light that is outdoors that apparently is beneficial.
Okay, thank you. Do we have any other questions? Let's see. What could be the cause of blurred vision? That's the question. What could be the cause of blurred vision?
Anything. The most common thing that is treatable is a refractive error, a need for glasses. We all know that myopia is being able to see at near but not far away. Hyperopia is the reverse. Hyperopia, farsightedness, you see better at distance than at near. But this is hyperopia, seeing better at distance than near, is more for an adult. An adult who is farsighted has hyperopia, see better far away than up close. Up close, they need reading glasses. And the reason why I'm saying that is that the inner eye muscles of a child have very good accommodative power. They can accommodate, they can focus the lens to be able to see. And that can be done very well. There is a very small, tiny proportion of children who are prematurely presbyopic. They act like adults who are 45 years of age or older. But this is really very little. It's less than 1% of children may have premature presbyopia. And these are the only ones that benefit from bifocals. But these are, good bifocals, a +2.5 to +3. They're not the bifocals that we see around with a +0.5 or something like that.
Okay. And what could be the cause of restless eyes or ever twinkling?
Many a time there is no reason. If we're talking about blinking quickly or eyelid twitching, most of the time it has no etiology. It comes and goes. Sometimes it's associated with stress. Sometimes, rarely, it's associated with astigmatism, and sometimes associated with allergy. So allergy and astigmatism are the most true common causes, but they cover maybe 20 to 25% of patients or people who have twitching of the eyelids. I always advise, and it works, to break the cycle by washing the eyes with cold water. If there is any irritant inside the eye, that will wash it out, and the cold temperature usually will relax those eye muscles those muscles in the eyelids, and make the twitching go away.
Okay. Next question, are blue filter glasses recommended at this time? And the second question is myopia associated with amblyopia or vice versa?
Okay. The first one, blue light, blue glasses, blue filter glasses, a lot of studies have been done after an original study of 10, 15 years ago that advocated use of those filters. All the studies have now proven that they have no effect, no true objective effect. So the answer is no. Myopia can cause amblyopia. If an eye is significantly myopic and the other one is not, then the child will accept and use the eye that is less myopic and forget about the eye that is myopic. And that more myopic eye will become lazy. But this is only if the difference is very big. And the reason why it is the case with myopia and not with hyperopia is that in a child with one eye that is normal, they use that normal eye for distance, and they use their nearsighted myopic eye for near. So they are alternating between one eye and the other and do not develop amblyopia, which is decreased vision. So again, with myopia, the difference between the two eyes should be large enough for the child to prefer one eye and not the other. Very high myopia, very high myopia can cause bilateral amblyopia, but it is uncommon to happen.
Okay. And we had a two-part question, best water for washing the eyes, and is soap necessary for eye cleaning? Best water is in
Cold water from the tap is as good as anything. The colder the temperature, the better off it is. Soap, no, not, I mean, for the eyelids and face, yes, but I mean, not for the eyes themselves. Definitely not.
Not for the eyes. Okay. Are there any dietary recommendations for children's eye health?
Not really, not in our area. I mean, the vitamin D deficiency, unfortunately, still exists in some part of the world, but in America, no matter what society in America, this is not present right now, unless the child has a medical condition like an intestinal problem that they have poor absorption. That is not the case. So the answer is no.
Okay. One more question. Should someone be concerned if having eye twitching every day? Does it mean that person has a vision problem and should get checked even though that person's vision looks fine?
As I covered earlier, the only vision issue may be due to astigmatism. It does happen, but rarely. So, again, if it exists for several months, I think it's worth looking into.
Okay. Do we have any more questions? Okay. Well, thank you. We are grateful that you joined us for this beneficial conversation. Thank you, Dr. Jafar and Sean, for sharing valuable information and resources that highlighted the importance of children's vision health as it relates to overall health and academic success. The Prevention of Blindness Society would also like to thank Dr. Jeffrey Y.H. Chung for sponsoring today's event. And I am going to turn it over to Karen Forston.
I just want to thank everyone again for joining us today. And I wanted to also make an offer to anyone in the listening group, either today or if it's listened to in the future. Please feel free to reach out to the Prevention of Blindness Society if we can help in any way. We do trainings, we have lots of information, and as you've learned today, we have resources that we are continually updating. So it was great to hear about some new resources today, and anything else that we learn about, please, we will share it, and please share it with us. We are a community of individuals working with our community. And so while we want to share what we know, we love it when people share what they know with us too. So I will close for today. Thank you for your time. Thank you for your attention to children's vision. It's really important, and we're grateful. Thank you.
Thank you all. Children are our future.